Hello, everyone, and welcome to this week's edition of MOJO Rising, How to Make Cancer Suck Less. This is a really exciting topic we have for you today, because for anyone who's interested in cancer, we're going to talk a lot about radiation. Radiation has been in use for over a century, with the earliest roots traced back to 1895. And data shows that almost 2/3 of cancer patients might be treated with radiation at some point in their life. So this is a really important conversation for us to be having to bring you the very best of our research and knowledge. And I brought together three of the most impressive guests I possibly could to help us with this conversation. You guys might remember Dr. Chad Levitt, a 20-year veteran oncologist here in Atlanta, Georgia, from an earlier podcast episode. He has a very interesting background and certainly is not the run-of-the-mill oncologist, because he started his degree studying philosophy. He then went on to medical school. He's worked in a variety of different patient care settings, from Florida to Georgia to Colorado, and most recently has opened his venture, Onc Care Specialty Consultants, to help patients really understand all the options they have to consider in their healing journey. So he's what I'd call a patient-first doctor, meaning he strives to put himself in the shoes of the patient at every single moment. So really excited to have Dr. Levitt back with us today. We also have a very exciting biochemist, environmental scientist, but also a breast cancer thriver. So I can't wait to have Joanette with us today, also known as Jet. So if I call her Jet, that's why. But she is just a firehouse of information. She's going to share so much with us when it comes to her experience developing a comprehensive approach to optimal health. She does this by identifying environmental stressors and providing strategies to help unlock the body's innate ability to heal, which we know is so critical for us patients to be really focused on how we fire up that immune system and get everything running in full speed. And then last but not least, we have our Dr. Kedar Prasad, who has a master's degree in zoology. He is the first ever PhD in radiation biology. He received his postdoctoral training at the Brookhaven National Laboratory in New York and joined the Department of Radiology at the University of Colorado Health Science Center and became a professor and director for the Center of Vitamins and Cancer Research. And you'll know that he has a year or two more than any of the rest of us on the call of experience. And he's coming to us as one of the most impressive 89-year-old men I have ever met in my entire life. So really excited to bring these folks together. Dr. Prasad has more than 250 articles who have been published, over 25 books in the topics of radiation biology, nutrition, and cancer. He's an expert in the arenas of antioxidants in cancer, which I know so many of you have questions on, and most recently got a patent in the area of cancer. So we will make sure we spend quite a bit of time digging into those areas. But without further ado, Dr. Levitt, would you share a little bit around, in your experience, what are some of the reasons why someone would use radiation instead of chemotherapy?
Sure. Well, thanks, Julie, again for having me. Excited to be part of this. So a lot of what happens with modern traditional Western treatment for cancer is often involving radiation. And my experience is that just that word, just like the cancer word, and just like a lot of other things, it means a lot of different things to a lot of different people. And scientifically, we use radiation in a lot of different methods as well. For most patients dealing with a cancer diagnosis who are introduced to the idea of radiation treatments today, it's better thought about more along the lines of being similar to surgery than it is to drug therapies or targeted therapy or chemotherapy that goes throughout the whole body. Most modern radiation treatments use a machine that focuses high energy X-rays. X-rays are a type of radiation at a very focused target to deliver a high dose of X-ray radiation, through invisible means to destroy either a tumor or microscopic cancer cells in a specific part of someone's body. And by doing it with modern techniques, utilizing all sorts of computer technology and planning and really well-engineered machines, it can focus on a bullseye, and the goal is to minimize the lower doses of radiation that might be exposed to the surrounding tissues. This is very different than what a lot of people are afraid of when they hear radiation, where we talk about whole body exposure and the risks of radiation causing diseases. And there's two elements. Low dose radiation to the whole body and to normal tissues is a big danger and concern that we're going to hear a lot about today. High dose focused radiation is aimed at a very specific part of someone's body, and it does a pretty darn good job at minimizing low doses of radiation to the surrounding tissue and definitely to the whole body in general. So to answer your question more specifically, chemotherapy and drug therapy and vitamin therapy goes throughout the whole body and is aimed at doing all sorts of things to strengthen the normal immune system and the normal cells while destroying or weakening cancer cells. Radiation today is much more focused on a small area with a much higher dose than historically what people are afraid of when it comes to power lines or diagnostic scans or infusional radiation, which is still relevant but far less common.
And when would you say that transition between kind of whole body to more targeted, like when did that take place? Is that recent or has that been a couple decades?
Ever since radiation was utilized to destroy cancer cells, the initial Madame Curie discoveries and utilization was aimed at applying radiation in high or therapeutic doses to the tumor cells, the cancer cells themselves. The safety concerns and understanding in science really became much better understood in the decades after it was introduced as a therapeutic option. But it's a very, very, very rare situation where therapeutically we're aiming radiation doses at the entire body intentionally. So there wasn't necessarily a divide, and these concerns are in parallel, but often confusing to patients because people think of radiation as one giant topic, but where it's applied, when, and how is very critical to someone's understanding to be able to categorize what concerns or protection they might need.
How do you identify how long or meaning how long in weeks, how long in session, how much dose? Like, how do you identify all those per the exact patient?
This is the part that's been really evolving. And honestly, in the last 15 to 20 years, more rapidly than in any other time beforehand, as far as our understanding of what organs can tolerate what doses of radiation. Today, we understand that exquisitely more than we had in the past. The skin versus the lung versus the heart versus the esophagus versus the brain versus the lens of the eye. They all have different tolerances for doses of radiation, but that's also combined with how do we deliver radiation, focused or therapeutic radiation. Very high doses can be delivered in short treatment sessions today with actually better outcomes, an enhanced ability to kill tumors and tumor cells than we had in the past. This is a combination of better engineering to focus the high doses on the bullseye much better than we had ever had in the past, as well combined with the biology of our understanding of what is therapeutic and what is safe. Safe on the normal tissues, therapeutic on the bad tissues. And that's something we talk a lot about in the modern radiation treatment setting, what we call the therapeutic ratio. You want something to be very highly effective at killing cancer cells, but minimally damaging to normal cells. And so the best scenario is a very high therapeutic ratio where you have great therapeutic outcomes and almost no damaging outcomes. And we're always working to to tweak those two or enhance those two goals. So a lot of what Dr. Prasad will probably talk about today originated in the ideas of how to protect normal cells and enhance therapeutic cells, but he's come a long way in making those options and solutions applicable to people both with a cancer diagnosis as well as to people without.
What are some of the typical risks of radiation?
So that's a great question. It depends where in the body we're talking about. So if you think about it like a surgical tool, whatever you've got to go in and get close to could potentially be damaged. So if you're dealing with a tumor in the chest that's close to the esophagus, let's say, or the spinal cord or the heart, you could cause damage to any of those organs, both in the short term or in the long term. In the brain, the optic nerves, the chiasm, the central parts that control our short and long term memory, are all well understood as being potentially damaged areas. But if a tumor is far away from them, it's not necessarily as much of a safety concern. And so we could go through the whole body and talk about focused radiation's ability to irritate or damage different parts of our different organs or different parts of our body. And that's separate from what can be concerned as long-term risks, where radiation can actually cause disease and can cause cancer if not strongly taken into consideration on how to protect those patients. And then this is more of an adult topic, but when it comes to radiation in children or developing or prepubescent animals or humans, the long-term effects on growth and development are critical. And so that's a different specialty topic that we enhance our understanding and concerns about protection and therapy with as well.
And then, oh, sorry, did you have something else to share, Jet?
No, I'm just in awe. Thank you, Dr. Levitt.
Yeah. Okay, and then one last question, and then we'll flip over in just a minute. So, Dr. Levitt, when you think about the traditional experience for the cancer patient, what was that like? What were the side effects? What was like anything that you would share there, or tips? Well, we'll get to the tips in a minute. So let's just talk about the typical experience first.
You know, the typical experience today is, as we've talked about on our past discussion, is often just in the understanding, confusion, anxiety, and the deer in headlights syndrome that most cancer patients go through. And it's not that most all doctors and treating physicians and care providers don't want to take the patient's experience at heart and make it the central focal point. But the bandwidth of taking care of patients in the institutional medicine systems is really limited. And so most patients just are left, they're left not knowing what questions to ask. And those are the ones that revisit them in the wee hours of the night when they're thinking to themselves and they stumble upon, well, wait a minute, radiation's scary sounding, or surgery scary sounding, or chemotherapy or drug therapy. And it's really a lot of inability to know which questions to ask, and then confusion about some of the answers. And we don't get a lot of great training in Western medicine. We get great training, but we don't get a lot of great training in how to communicate, what your style is. It is not a one size fits all. So we can't all connect the way we would like with every patient, but focusing in on making sure the patient understands what their options are and the pros and cons of each of those things, really focusing on the step in management called informed consent and giving them the ability to be an active participant in those decisions before they just reflexively accept what might work for a lot of people but may not be the best fit for them, is really the pitfalls that we're all trying to fill with collaborations like this.
One more question. I said the last question, but I have one more for you. And that is, when is radiation the best option, in your opinion, versus when is radiation not a good option, but it's typically used? So anything there you would say to help guide our listeners?
Um, Radiation often is used today as an alternative to surgeries. While historically big surgeries and removing the whole tumor itself is often the best option for small or early stage tumors in different situations, breast, lung, rectum, colon, things like that. Um, there are certain situations or certain patients that are too frail or have a contraindication, meaning some reason not to go through an invasive surgery that might delay their chemotherapy or might pose a very difficult risk in their healing after surgery. So radiation in those settings often is a good option to consider. While it may not have the same track record historically as surgery, today we're undergoing lots of studies or participating in lots of studies showing an equivalency. Um, Additionally, in patients who have had surgery, where we know that there's a very high risk for some little microscopic cells to be left behind after the surgery, radiation does do a really effective job at cleaning up those areas where we know statistically that if you don't do something more, that tumor may just come right back after the surgery. So in settings where it's not a great option, is where it's not really evident that it's necessary. We have got so many exciting things happening in the systemic, meaning the whole body treatment option world when it comes to immune therapy and things called targeted therapy and addressing the microbiome and micronutrient and non-traditional types of treatments that can enhance the cure rate of many cancers. Radiation actually is having less and less of a necessary role as we make advances on all of those fronts.
Great. Thank you so much for helping to just kind of set the background for everyone to really understand radiation and how it can be used. All right, Dr. Prasad, would you mind sharing with us a little bit about your research? And we'll start there, and then I'd love to ask you some questions about your patent.
Okay. Yeah, my research has been in a different directions, but with respect to cancer, the major finding is that high, or we call a high dose, but now I'm calling therapeutic dose of antioxidant can kill cancer cell, but not normal cell, one. Second is the therapeutic dose of antioxidant can enhance the effect of radiation and chemotherapy on cancer cell, but either protect or have no effect on the normal cells. There have been, for example, in a chromosomal damage criteria, high-dose antioxidant protected the radiation alone, high-dose radiation alone increased the chromosomal damage, but when you treated them beforehand with a chemotherapeutic agent, then it was protected. So this is very important to remember that therapeutic dose of antioxidant can enhance the effect of therapeutic agents such as chemotherapy, radiation therapy, or I don't care, immunotherapy, could be any kind of therapy. And so this is very important to remember it. And so now the question is that in case of radiation, how we can do that so that people can accept it, because it has been published many times, but nobody believed it. And especially oncologists, so that radiation or chemotherapy people, they did not accept it because they did not know the difference between the therapeutic dose of antioxidant action of and also preventive dose. But because if you use a preventive dose, means low dose of antioxidant, it will protect both normal cell and cancer cell, and therefore it will be counterproductive. But opposite is true. High dose of antioxidant will actually enhance the effect of therapeutic agent and cancer therapeutic agent of all kind. So the question was, what is happening What is the difference between the action of therapeutic antioxidant and preventive antioxidant? And it occurred to me while I was doing research that do cancer cells require a specific nutrient for survival? And looking for the literature, we found out indeed cancer cell require glucose and glutamine, two must have for survival. Glucose for energy, glutamine for making vital molecules for their survival. So if you block them, then they will die. And it makes no difference what kind of cancer is. As long as the cancer is, they use the same pathway. So this is very important to remember it. And then when I looking at the literature, indeed, we found that high dose of antioxidant, and they will inhibit the uptake and metabolism of both glucose and glutamine. So the cancer cell die because they can't generate energy, they can't make any vital molecule for survival. So that's why it is so selective killing. And so, well, this is important to remember. Another thing very important I want to mention it with respect to radiation therapy. Probably Dr. Levitt knows that there is a recent advances in technology that call flash radiation therapy. And flash radiation therapy can deliver 40 rad per second compared to conventional radiation therapy, where there is a 0.01 GY, not rad, 40 GY per second compared to conventional radiation therapy is 0.01 G radiation. So you can see there is 40,000 difference in dose rate. And Dr. Levitt was mentioning the higher the dose rate, just a major radiobiological principle, higher the dose rate, greater is the damage. But in this case, this was violation because that's ultra high dose rate. The tumor response when they compare was exactly same as conventional therapy. So there was no change in tumor response. But they protected to some extent, they protected the normal tissue. So that was kind of interesting idea and comparison. But in that scenario also, they did not consider that whenever you radiate in tissue, that is an effect called bystander effect. In other words, the dead tissue of tumor tissue and normal tissue, they generate pro-inflammatory cytokines, and that migrates and can distant organ. So, for example, people who have been treated with radiation chemotherapy, with the colon cancer, say, for example, and then the much later, people can develop breast cancer, which was induced by the bystander effect of radiation. So 10, 15 years, you have risk of reoccurrence, but most likely is the tumor occurs in a distant organ, and it is not a primary tumor. So that has been ignored in that study, and they have not considered it. But we have considered that issue, for example, and so that it can even improve the flash radiation therapy, which is there, is the response rate is same. So we wanted to also increase the response rate so that it is more effective. But that technology we don't have as yet. Probably Dr. Levitt knows it. This is still in European technology, but this is upcoming. People are very excited about it. And it is good for the patient because it doesn't have to go 6 fractionated therapy. It's just 1 dose in a second and you go home. But anyway, so that's one thing. So even right now we are concerned. So our patent, for example, now we explain it, that why high dose radiation or therapeutic dose of antioxidant is effective just killing this cancer cell. So this will make the oncologist more comfortable. At least they can think, and it is non-toxic. There's no toxicity involved.
You know, we on our podcast that we launched this past week with Jenny Smith, who is a stage 4 recurrent triple negative breast cancer thriver, who just was declared no evidence of disease, talked about this exact same thing in how she had to advocate for herself with her oncologist to move past the initial, no, vitamin C is bad, and was able to push back using the research that you're mentioning to say, no, high dose vitamin C actually does help. And she's had an incredible response. So we just had a patient talking about this exact same thing in the podcast we launched this week. So we're excited to be sharing this as well. I'm really, really excited to know this. But let me ask you a little bit of a background question. Knowing that you're the first PhD, how did you get into the field of radiation biology to begin with?
Well, I think when I was in India, I saw that Hiroshima and Nagasaki newspaper. So I thought that I should develop a radio protect. I was moved, I was a teenager. And so I said, maybe I should develop some radio protective agent which can protect human against radiation damage. This was my idea. And then after my graduated MSc in zoology, my background was zoology in Bihar, from India, state called Bihar. And but I was not very happy. Zoology, nothing to do with radiation biology. So then I applied to 5 or 10 university for a scholarship in US. And I said, I'm interested in radiation biology. But I ended up in a Southern Illinois University for 1 semester, but they have only UV radiation. They didn't have ionizing radiation. So I got desperate and then applied for Iowa City Radiation Research Journal. You may be knowing it. The editor, Titus Evans, was the director. I wrote him a letter and he said, yeah. He gave me more money and became assistant. And in 3 years, I finished my radiation biology program. And while doing so, I developed a radio protective agent called methylamines, but that is toxic to human. We saved all our rat and mice animal. If you give them beforehand, MEA we used to call it, and then they was very protective. And the reason was very protective because that has some antioxidant and caused some hypoxia, and so it was protective, but it was not. And then when I went to Brookhaven National Laboratory, there I started working with the guy who discovered L-DOPA treatment of Parkinsonism. So I got training in Parkinsonism. And so then when I came to Denver in the Department of Radiology, and my job was to teach radiation biology to residents in radiology. And there I saw a paper. I was working on neuroblastoma cell in culture. And there I discovered that if you elevate cyclic AMP, it becomes a mature neuron. At that time, it was thought that once you have a cancer, you cannot reverse back to a normal phenotype. But in this case, it did. And for that, I got a lot of fame and a lot of money from NIH for my research. And then I saw a paper by Dr. Pauling that vitamin C is very effective in cancer treatment. But other people could not confirm his work. And so he thought he's a crazy guy. But I thought that he's a 2 Nobel laureate. He can't be that crazy. So I tried to reproduce his work on my experimental system, and I found that he was correct. It kills cancer cell and not normal cell in experimental model, and further extended the effect, saying that it increases the effect of chemotherapeutic agent and radiation on a cancer cell, but not on a normal cell. And so that's very interesting. And then I thought, oh, it is vitamin C. How about vitamin E? So I asked my technician to order all forms of vitamin E and found out vitamin E succinate was the most potent anti-cancer agent by itself. And
say that one more time. Vitamin E is the most
succinate. Vitamin E succinate,
okay.
Not acetate. Acetate was totally ineffective. Most of the people in experiment, they use vitamin E acetate. It was totally ineffective. But vitamin E succinate, that was the first paper I published in cancer research. But now, if you go to PubMed, there would be a 500 paper on vitamin E succinate. So I found that it enhances the effect of radiation and chemotherapeutic agent on cancer cell, but not on normal cell. So this way, continue to do it. And then then I found out that it is better to use multiple antioxidants rather than single antioxidant. So,
Great. Now let's talk a little bit about this. So how would you suggest someone preparing their body if they were diagnosed with cancer and considering radiation? How would you recommend that they prepare their body so that they would not have the impact that they would?
First, this is very important, and you mentioned briefly that a cancer patient, if you have a diagnosed cancer patient, they have already, we call it intestinal dysbiosis. Intestinal dysbiosis means composition of bacteria have shifted in favor of toxic bacteria or harmful bacteria. And these bacteria produces a very toxic chemical, including pro-inflammatory cytokines, and that they can damage gradually all your organs. And as a matter of fact, there is a literature that in a colon cancer treatment, they did not correct the intestinal dysbiosis. So there was just like a regular patient, they had intestinal dysbiosis, and that reduces the effectiveness of chemotherapy. And person develops a resistance to tumor, and of course, then person will die. So it is very important for cancer patient, before going into any therapy, you must have your intestinal biosis, probiotics with prebiotics, and we have our company has excellent formula, and so probiotics has been filed for patent, and I think it will be issued. Yeah.
I also want to say Dr. Prasad discovered butyric acid.
Yeah.
So that short chain fatty acid, and so way years ahead of where we are now, looking about the dysbiose. I just wanted to edify him that was his work, that he discovered butyric acid.
And can you just, while you're explaining that, can you explain why that's important?
Go ahead, Dr. Prasad.
Yeah. And so when you shift, when you take a probiotics with prebiotics, then it does two things. First, it restores beneficial bacteria. And then as you know, the bacteria produces a lot of vitamin K, some B vitamins, neurotransmitter, and some very beneficial thing for your health. But also one of the major function of the probiotics is that's why prebiotic is very important, that it ferments prebiotic and generates what they call short chain fatty acid. Among those three, acetic acid, propionic acid, and butyric acid. Among these three, this is a 4-carbon fatty acids and very small. And among them, butyric acid turned out extremely powerful anti-cancer agent. And at that time, when I discovered it, I wrote a paper. There was only one paper. There was no literature on this available. Now, if you go in a PubMed, you will have a 500 paper on butyric acid, not only as an anti-cancer agent, but it has many other important function for your body. So then now butyric acid is extremely important.
Well, so, I think gut health is important for any diagnosis.
Gut health, and also gut health is very important. If you are younger, this is not the issue. But if you're an older person and have cancer, that also, as you grow older, digestive enzyme production reduces. And therefore, not only you take a probiotics with prebiotics, but also you should take a digestive enzyme, because then all the protein, carbohydrate, fat get digested easily. Then you don't have constipation or any kind of, even during therapy, sometimes it happens. Some medication can induce constipation and so on. Or not only that, somebody can alter intestinal composition of the intestinal bacteria. So in order to prevent that, it is very important for a cancer patient to have a probiotics with prebiotics. And the only thing I don't recommend cancer patient is collagen peptides. And the reason is for a collagen peptide, because generally immune system send a tumor cell killing T cells that kill tumor cells. So tumor grows slowly. But what collagen peptide does, that it blocks the entry of those useful tumor killing cell to the tumor environment. So tumor then grows rapidly. And therefore, I think collagen peptide is the only one I said you should not take it.
Okay. Now, Dr. Levitt, when you think about the same question I'm going to ask you, is there any things that you would have suggested a patient do besides preparing their microbiome to prepare for a successful radiation experience?
Yeah, I think successful radiation administered back, and also take a therapeutic dose. I suggest generally take a therapeutic dose a week before your radiation or any kind of therapy you are going to get.
Okay.
The result is that in a week time, with that kind of dose, tumor will shrink.
Perfect.
And
Okay.
then when you come to radiation, then it will not cause normal cell damage, but you will have a tumor cell damage, and it will continue not only tumor cell, which is acute, but also potentially later on, then it gradually reduce to a preventive dose, because you can't take it forever, that kind of therapeutic dose. And so when you say that then gradually reduce to preventive dose and continue through your life, so that you don't have any late adverse effect of any kind of therapy.
Okay, so when you say that, let me just quickly clarify, because I want to clarify this. This is a question I'm pretty sure our audience will have. What is the difference between a daily dose of vitamin C versus a high dose or a therapeutic dose? What would you say are the differences in that?
For example, the good example would be, say take for vitamin C. Vitamin C generally 100, 500 milligram people take it, that's it. That would be a preventive dose. When you talk about therapeutic dose of vitamin C, you are talking about anywhere from 5 to 10 grams a day. And so that's a vitamin E succinate, for example, is probably 100 to 200 international unit. But when you are talking about the therapeutic dose of vitamin E succinate, I don't give vitamin E acetate because they were inactive. And so vitamin E succinate, we do 2,000 international unit. And if you are taking other one, like, for example, resveratrol or curcumin, 1,000 milligram. So these are the high dose. And in my patent, I have given a specific formulation. But for the time being, when people ask me, because they are not available right now, what I'm talking to you, exact formulation that have been granted patent on that. But in the meanwhile, if somebody has it, then what you do? You have to come up with the best approximation.
And
so
typically, do you suggest that the vitamins be administered orally or intravenously?
Orally. I always say orally. And I never say do individually. We always believe in the multiple antioxidant, because sometimes high dose antioxidant in very high dose can be also generates free radical, get easily oxidized. So just that I don't do it. I always do in a multiple vitamin scenario. For example, in our situation that we have a micro daily EMF, and so preventive dose is like a 3 capsule in the morning and 3 in the evening is a preventive dose. And if somebody is going to cancer therapy, I say use therapeutic dose anywhere 3 to 4 times of the preventive dose. So for the time being as a transient, I recommend that. And some people who have followed this, plus of course, probiotics and digestive enzyme. And sometimes, like, Dr. Levitt was mentioning anxiety disorders, sometimes people go through anxiety, you have a cancer. And that scenario, if you feel really bad about anxiety and depression, then I also recommend a 50 milligram of the CBD.
Okay. Now, so let's, Dr. Levitt, I want to move over to you to understand from your perspective, is there anything else that you would have suggested to a patient do before they start radiation in the traditional conventional approach? So Dr. Levitt, anything you would add?
Sure. Let me also clarify, Julie, that a lot of what Dr. Prasad is discussing and that we're discussing here is not related only to radiation treatments. In fact, the way radiation works and the way many traditional chemotherapies work is through this oxidative process where the oxygen inside of the nucleus of the cancer cells are triggered to become an oxygen radical. And it's that damaging oxygen radical that historically all of us, are worried about, and we take antioxidants, or people take antioxidants for minimization of those oxygen radicals to damage our normal tissues. Those oxygen radicals with traditional chemotherapy and traditional types of radiation are actually what destroy the DNA of the cancer cell. So a lot of what Dr. Prasad is discussing about the concerns from traditional oncologists that antioxidants can interfere with therapy is based in a historic understanding, albeit not nearly as evolved as where we are today. So what we're talking about here in preparation of the microbiome and prebiotics and probiotics and oxygenation and these other enzymes can relate just as much to supporting the body going through chemotherapy as it can to radiation, and actually probably even more so with the drug therapies than the historic or modern worries about radiation treatment. So without getting too much further deep into the science, some of what Dr. Prasad was alluding to with flash radiation, or what we call hypofractionated ablative radiation, these really high doses or really concentrated doses of radiation energy overcome the mechanism that uses oxygen radicals, and actually the energy itself destroys through what we call direct interaction or direct effects the DNA that we're trying to kill anyways. So some of the more modern radiation techniques and a lot of the new drugs, targeted therapies and immune therapy, work outside of this oxygenation pathway where historically there's concerns about interfering with the effectiveness of the treatments. And so that opens up a big window of opportunity for everything we're talking about here to realize the benefits of these oxidative treatments to support and strengthen the immune system while further weakening the cancer cells in a synergistic way than ever before. So in preparation for patients going through drug treatment, immune therapy, targeted therapy, radiation treatments, I focus a lot on what we're talking about here, enhancing the strength of the patient's immune system and their body without interfering in a certain way. We talk a lot about approaching disease, wellness, and disease prevention from a place of strength and trying to really support without the normal body's ability to heal and prevent disease without interfering with the effectiveness. So there's a lot here that is really helpful that we're talking about, but this is early in our modern Western scientific understanding, and it's really confusing because patients often do find themselves in between a traditional type of physician's minimal understanding of nutrition and gut health and oxidative therapies, and knowing that there's a lot more here that we don't understand, and trying to figure out how to apply it in a specific way to each of their journeys is really the challenge. So really every patient needs to be taken on a case-by-case basis to say, what is your stress level? What's your nutrition like? What's your exercise like? And addressing all these pillars that we've alluded to, I think, in our past podcast of integrative medicine and wellness.
Yeah.
Anything you'd add to that, Dr. Prasad?
Yeah, no, I think, but only thing that I want to emphasize is that whatever he said, diet, lifestyle, exercise, all these things are important. But also therapeutic dose of antioxidant should not be confused with the preventive dose of antioxidant while you are recommending it. And, many times patients go and just buy vitamin from the marketplace, but that can be a counterproductive, whether you're radiation therapy. And even though, modern therapy, even though has become very important in terms of focusing on radiation on a tumor cell, but there's still some normal cell around the adjacent to the tumor gets damaged. And that can be that the repair or could be a late consequences later on. So those kind of damage can be protected by addition of, for example, therapeutic dose of antioxidant, and also probiotics with prebiotics. This is very important, some digestive enzyme. But overall, you give a inner strength, because that will also improve the immune function, because this is a very central issue. While you are treating that, you should have also immune function in as much at best as you can. And so the combination of this holistic approach of diet, exercise, and this, and the therapeutic dose of antioxidant, and later then you worry about preventive. First you have to cure the cancer, and then worry about it, And so in this way, right now, 5-year survival rate is very good.
Mm-hmm.
With the conventional therapy right now, we have radiation or chemotherapy, but then again, in some cases, relapse occurs, some cases this and that, but you don't do anything to normal tissue. With our approach, you can not only increase the 5-year survival rate, but also you can reduce the damage to normal tissue, acute tissue, and late adverse effect, which is bystander effect, indirect effect of radiation. Even tumor tissue releases toxic chemicals. Even tumor tissue, after they die, radiation or chemotherapy, they release toxic chemicals, and they migrate through your bloodstream to various organs.
Okay, so let me make sure I understand for our audience. When you say our approach means to use high dose or our therapeutic doses of antioxidants plus probiotics and prebiotics.
Yes.
Diet, lifestyle, exercise, things like that. Is there anything else that you would say is part of your approach that we haven't uncovered?
No, I don't think so. For me, I mean, some other people might have some other suggestions, but I think these are the most important thing for your health. And therefore, I think,
is there anything you would suggest specifically to help either during or after radiation to repair damage?
Yeah, I think the same thing continue. For example, after therapy, I continue, say, for another month, same therapy, and then gradually reduce to preventive dose. Because if you suddenly start tomorrow, the body will feel as if there are deficiency of vitamin C, and you may not feel comfortable. And so from transformation, from therapeutic to preventive dose has to be gradual.
Taper.
Yeah.
Tapering.
Yeah, tapering off.
Tapering, yeah.
Perfect.
Otherwise, otherwise maintain that thing through your life, and you will have a healthy, enjoyable life.
Okay.
Also add, Julie, that it may be obvious to the people here on the panel, but cancer there is no like one cancer. Okay.
No.
Every type, there's a lot of different types of cancer, and some are more resistant to treatments than others. And so not only are there different types, but where they are found in the body are critical as well. And so some of what we're talking about in protecting certain organs with a holistic approach are more significant and important than others. There's a long history that Dr. Prasad's been a part of as far as looking at things called radiation sensitizers, where we give people things that help the radiation work better to kill cancer cells. And then there are radiation protectants, which help protect the normal organs from damage to the radiation. And there's a few classic examples that have made their way into Western medicine, but it's not been universally utilized or agreed upon. And so we're touching on just the really tip of the iceberg on some of these topics, where a lot of nutrients, micronutrients, vitamins can be used to do both, to prevent as well as to sensitize, as well as to
sensitize. Exactly.
What would be some of those that would be beneficial to both do, as you just said, so sensitize and protect?
Well, I think you touched on vitamin C therapy doses. I am interested because, admittedly, while I'm probably more self-driven to learn about nutrition and some of the integrative therapies than we just learn in medical school or in fellowships. My understanding currently is that the route of administration, meaning the way you deliver therapeutic doses of antioxidants, does matter. Maybe it's just a matter of how the doses make their way into the bloodstream, but my admittedly, less experienced understanding of therapeutic vitamin C, for instance, is that when delivered through an IV directly into the bloodstream, it's not metabolized to some of the enzymes and molecules that can interfere with treatment, and it actually bypasses some of that process. That might just be, to Dr. Prasad's point, that it's just a more efficient way of delivering therapeutic doses that are different than the preventative or daily doses most people do use that traditional doctors and oncologists are concerned about for interfering with the therapy of their treatments.
Yeah, well, that's the reason we have produced what is called a hydroform of microdaily EMF. And hydroform is, it is the lipid soluble, somehow they use some chemicals or something to solubilize it. So it is now, you can put in a glass of water and put a, say, therapeutic dose of 3 capsules and dissolve it, shake it. And when you take it, it is rapidly absorbed because it is already uniformly distributed. It is rapidly distributed through your organ. Only problem is this: if somebody has a brain tumor, then this is a different issue. Their high dose antioxidant, I don't know, will be sufficient amount go to the brain. I know for example, vitamin E succinate, I know it can cross blood-brain very easily. But there I have suspicion that I don't know how much it will be effective. But hydro, instead of, say, for example, giving IV, and sometimes if you give IV, but if you are, suppose you are also giving but they also can generate some free radicals because, as you know, vitamin C is easily oxidized, can generate free radicals. And so that may not be as effective as it is done with combination with other one. So you take the advantage of vitamin E. At the same time, when they get oxidized, they don't produce free radicals. So our goal is like that. And our goal is, the patent goal is to get eventually FDA approval for this, because otherwise you and I can try as much as possible in the meanwhile. And yes, Joanette.
I wanted to say, for the preventative dose, Dr. Prasad already has $24 million in research that's a 2-a-day dose. And I think that that's really important. He already has done that research, so he knows it's really important because of, and then also there are different types of free radicals that's why it's a multi-micronutrient approach. His research, his body of work is not just one antioxidant because it doesn't quench all free radicals. This masterfully crafted novel approach that Dr. Prasad is presenting is it's very well thought out. And so when you look at one antioxidant like vitamin C, it quenches certain free radicals, but not others, and it oxidizes quickly. That's why he has vitamin E succinate and other micronutrients that he has tested in 24 million in research that's safe with no medication contraindications for prevention. Now, when we're talking about this therapeutic dose, which is so exciting that Dr. Levitt's on, and that it stops, inhibits the reuptake of both glucose and glutamine in cancer cells, but still safely delivers those nutrients especially the glutamine, to normal cells. We can't not have that. And I just wanted to share that his body of work is really, and he was friends with Linus Pauling. So he's got all kinds of stories of the two of them, but his work, his body of work is really through a multi-micronutrient approach, the right amount and the timing and what's not in it. And those things are as important as what is in it. Because if you take things on a daily basis, like some trace minerals that you don't need, he didn't put that in because when we're in a cell danger response, our body it sequesters them. It has no way of getting them out. And so his body of work is just, I wanted to really clarify that. And then last couple things, Dr. Prasad has a patented children's gummy that will protect from oxidative stress and inflammation simultaneously and from 5G. It is the first patented children's gummy out there.
Yeah.
So that particular product is available to be used with children before and during. So I wanted to share that because they're the most fragile. And I think that when it comes to delivery, Dr. Levitt, these are such great questions for on so many levels and just scratching the surface. But his body of work on 24 million in research with both animal and human, he has a lot of understanding of dosing. And I think that really his work will go to lead to more timing and dosing of things, and how, those are really important questions. And I'm so glad, we got to have that. But thank you for letting me interject, Julie.
I was gonna say, so tell me a little bit, because I want to make this actionable for our listeners. So is there anything here that you would suggest, either the research they share with their doctors or research that they can read and understand? So anything that you would say, like, to make this a little bit more actionable for someone, something someone can do today, anything you draw forward from the research that's been done?
Well, I mean, the only thing I can refer it that I have preparing a manuscript on this issue. I have not submitted it because of until I get the patent number, I won't. But a summary of that I can submit to you and for everybody to know how it should be used. What are the, I have given the detailed protocol there. And so that's another possibility that I can do. I can send the information to Joanette, and you can. But the idea is to promote that the therapeutic dose of antioxidant is different than preventive dose. Their mechanism of action is different. They may have the same ingredient, but mechanism is different. One protects free radicals, another has nothing to do with free radicals. They block those kind of things. So the best thing would be to maybe I can write some protocol, whatever. Another thing in protocol depends upon what is available right now. If you go strictly on my patent, the product is not available. They have to manufacturing, have to make it. Those kind of things. So the short term. So in a way, what I said, therapeutic dose, like 3-4 times the micro daily EMF that we have hydro. So I can write a protocol for you, send it to Joanette, and then share with you.
That would be so great.
All right, Julie?
I would love that, because I think our listeners are really going to want to know that and know what to do. So, okay, now I've got a couple of big questions, because this is scary for a lot of people. We've hit the mental health part of this, and there's a couple of specific things that do tend to make people a little bit more scared. So I just wanted to ask if we could do a lightning round of a couple of things that do make people a little scared about this, to understand what you would do to alleviate those fears. Okay, so the first one is, any ideas around blood clots or high clot risk or anything around that? Like, that is something that people have mentioned to me as a concern with radiation. Is that a valid radiation or a valid concern, or anything you would suggest doing to reduce that worry?
Yeah, blood clot side effects of radiation, blood clots is very unlikely, but sometimes the heart, depends upon where the radiation is being delivered. But anyway, in case of say, for example, clot, I think one micronutrient has been very effective is citrulline. Have you heard citrulline? Citrulline, citrulline. Okay. Watermelon is very rich in citrulline. And one of the functions of citrulline is that first it is absorbed very easily from the gut. And then when into bloodstream, it turns into arginine, produces arginine, and arginine produces nitric oxide, which is a vasodilator. And so, but if somebody have a chronic disease or blood clot, then should consult a doctor, and doctor has a medication for that. But for prevention point of view, I think if you take some, say anywhere from, it is very non-toxic, say 200 to 500 milligram of a citrulline, and if somebody has a problem of, blood vessels narrowing or something, this can dilate it and can provide relief.
Dr. Levitt, anything you'd add about blood clots?
Not something we would focus on as far as a risk related to radiation treatments.
Yeah.
Patients with cancer in general are more prone to developing blood clots, so a preventative approach generally makes some good sense.
Yeah.
But I would just say that would not be a appropriate use of someone's stress or anxiety to worry about when it comes to delivery of radiation treatments.
Okay, let's take one that's specific to perhaps people in my generation, and that is fertility. So that would be something that when you think about any woman who's going through cancer in your middle age, that is a concern that we should carry and weigh. So would either of you like to weigh in on fertility and radiation and the risk factors there?
So again, not just with radiation, often the chemotherapy is more toxic to the viability of the ovarian function when it comes to fertility. Ovaries are very sensitive to focused therapeutic radiation. So really just avoiding them and not hitting them or exposing them to therapeutic doses of radiation is a common strategy, such to the point that in some women, and this is a very relevant topic for people with breast cancer or cervical cancer or endometrial or ovarian cancer, if it's not brought up by your treatment team and you are of the age and interested in having children, to make sure it's brought up, because it can be addressed ahead of time in a number of different ways, from anywhere of freezing someone's eggs to actually in some situations where surgery is going to happen or there's no way to avoid exposure of the ovaries, we will actually move the ovaries out of the way of the treatment, and that can be done with a simple sling procedure. And while it sounds primitive, it's quite effective.
But also that this is an excellent suggestion. In addition to that, also if you take for example, during treatment, high-dose antioxidant, it is likely, nobody has done experiment, human trial on this, it is likely that the ovary or any normal tissue would be protecting from radiation damage or even chemotherapeutic damage. And so, if no other alternative is available, that will be worth trying it.
I love that. And I think many
because
women—
there is no toxicity. There is no toxicity involved.
That's exactly. Okay. Now,
actually, I tell you one anecdotal story. When I was in Denver, one woman had a problem of having a children. So jokingly, at that time, I had a micronutrient formulation early, and so a small company selling it. So the name of the product was Sevak, S-E-V-A-K, is a Sanskrit word committed to serve you. So I said, jokingly, well, I don't know, you try this thing, And after she tried 3-4 months, then she became pregnant, and a beautiful baby was born, and she named the baby Sevak, the name of the product that I had. So, but anyway, what I'm trying to say that, we don't know how all these things work in a real world. And so in case can't be avoided ovary from radiation or other treatment, chemotherapy, then second best thing is that use therapeutic dose of antioxidant during treatment.
Okay. Let's talk a little bit about another one that has come up a few times, and this is around fibrosis. So do you have any feedback or thoughts on how to protect your body or to reduce the risk of fibrosis after radiation?
Yes, I mean, the diagnostic type of radiation, right? Yeah, there has been one clinical study in Europe done with our product, and one CT scan one CT scan gives about 10 CGY, very small amount of radiation, and people thought it doesn't cause any damage. But this doctor who started the clinical study on micronutrient, one group got a CT scan one, and right after that, they took out the peripheral blood. And by immunostaining, they measured the double-strand DNA damage. And so you can stain this, and under the microscope, you can score how many cells are stained with that DNA damage. And so they were surprised that one CT scan caused the damage in a peripheral lymphocytes. And that means other places they must have damage too. And then another group then got tested this micronutrient an hour before the CT scan and did exactly the same thing. And they found that the reduction of the damage was over 55%. And another thing that they didn't do it because they did not consult me, because now radiation, first we thought for a long time that radiation produced free radicals during time of radiation, but radiation-induced free radicals now live 4 or 5 years longer. That's why it is very important, not only treat them before, but also immediately after radiation to take care of that long-lived free radical, which is mostly organic free radicals. And so this could have been a more dramatic result if they would have given another dose after radiation. So whenever I suggested, that we go for chest X-ray or breast X-ray, any kind of diagnostic procedure, you take micronutrient that we have before going, and then when come back home, then take another dose.
On that front, I'd be interested in your thoughts on the prevention of fibrosis, or maybe the enhancement of healing following surgery, because we have not come very far in minimizing long-term fibrotic changes as a result of therapeutic radiation treatments, not dissimilar from healing after invasive surgery.
Yeah, I mean, fibrotic, as you know, because the parenchymal cell is dead, then it's replaced by fibrous tissue. So the question is prevention is, how do you prevent it? And I can simply speculate at this point that if you use during treatment, the therapeutic dose of antioxidant, that fibrosis type of event may not occur, because fibrotic type of occur because the parenchymal cell is dead, and so fibrous has to replace it. And so I think this would be just my thought. I mean, I can't produce any experimental evidence, but if it is protected, normal tissue, for example, then there is no need for fibrosis to occur.
And then from a additional concern point of view, Julie, is that using lower doses of radiation in a more precise and accurate manner is really the best way today to minimize fibrosis when it comes to, let's say, breast radiation, a very common scenario. There are some things that we can use in the lung, which is also very prone to fibrotic change.
Yeah, lung fibrosis,
where we know things like molecules called like the TGF beta and other maybe more deeper understanding molecules can help, are related to the fibrotic changes that happen in the lung. I don't think we have an exact strategy on how to minimize it in all patients quite yet.
Yeah, but again, this thing is, the worst thing would be that it has no effect. Worst thing would be when there's no bacteria. And the best thing would be, based on what we know, it might prevent the fibrosis.
If we could dovetail, because as a breast cancer thriver, okay, Dr. Prasad was my guide 7 years ago at 50. And working for the Department of Energy, I had a lot of exposure to different types of radiation and biowarfare, and I had a lot of stress. And Dr. Prasad told me it wasn't my nutrients, because I was on his nutrient. It was my stress. So I worked on working on my mental pharmacy, Dr. Levitt. I worked on some very specific vagal stimulation. I worked on balancing my brain waves. And so I went through a bilateral mastectomy with the guidance of Dr. Prasad and his micronutrient, his one product. And I asked to do it without any pain medication afterwards. And so I did purchase it because both my breast cancer surgeon and plastic surgeon were very concerned. I purchased them, but I actually balanced my pain with my mental pharmacy, which that was Dr. Prasad's suggestion. He has meditated his whole life. Okay, he's up at 5 a.m. every day. This is, that's why he's so sharp at 89. Whatever he's doing, we all should be, doing. But with that, in 5 weeks, I was ready for reconstruction. The problem is I healed so fast at 50 that the most painful part was taking the tubing out, because I had healed so much faster than they had ever seen, because I wasn't taking pain medication. And so in 5 weeks, I was ready for reconstruction. And 3 months, I was completely healed with full range of motion. Okay, which is, and I have no lymphedema, and I had 3 lymph nodes and 2 taken out. Those are the things that people do not talk about that can be the quality of life and this tissue and lymphedema. And I want to know, I live 7 years now. I'm a cancer thriver. And Dr. Prasad and I just talked about this as he got his patent. So grateful for his work and guiding me. But it was also that part of my mental pharmacy for those on here, because every time you have anything that is a healing issue, you think it's cancer. And so it's really breast cancer and beyond for me, and being a thriver, and all those things matter. But I healed so fast, Dr. Levitt, that that was the most painful part of this massive surgery. And I did it without any pain medication. And in 90 days, I was all clear, and I've been all clear for 7 years. Thanks to Dr. Prasad and his life's work. And I'm just grateful to be on here today to get to just say all the things he's sharing is for humanity, because a lot of people are suffering, and his body of work is second to none. Just go Google him. Okay. And I'm just so grateful for you, Dr. Prasad. And thank you, Julie, for having me on to get to share my story, because I know these people out here, there is hope. And thank you, Dr. Prasad.
Thank you. Thank you, Julie. Thank you, Dr.
Yeah, I have to say I'm the exact same. I had the exact same experience healing, where I could live my best life the entire time. And that is something that is rare. And our hope, I know, after this session is for it not to be rare. But I have one final question, and we need to wrap up our episode. And that is, any suggestions for how to educate doctors after radiation so they factor that into their clinical approach? So anything that you would need to help our people think about how they would educate or communicate or talk about this, so they can make sure that anything beyond radiation is factored in. Is it needed to factor in so that they can have a better life?
I don't know. I taught it. I can lecture it. If you have a 20, say, physician, I can lecture them about it. But there is no clinical data for me to say, yeah, here is the clinical data. I can do a lot of experimental data, produce them, and I tell them that it's non-toxic, but it is up to them to follow. So I don't know how to educate them, except that when you, just like today, I learned a lot from doctor, and they, if it's a more both way, and then that will be one way of educating the doctors. Now, how you educate the patient, that would be through the Joanette. We sometimes we have a Zoom call and I always Zoom call when I recommend these things. I always say you consult your oncologist before adopting all these suggestions, because still this is experimental. But one thing for sure, it has no side effects.
That's great. Dr. Levitt, anything you would recommend to help people understand how to communicate this after radiation?
I would focus on what Dr. Prasad was alluding to, as far as to get adoption to for the modern practicing or treating physicians, just convincing them or compelling them to have an understanding that these things aren't going to be harmful or interfering is probably the lowest hanging fruit.
Yeah.
Convincing them of the mechanism of action and the clinical outcomes without the science is going to be a Sisyphean battle, meaning really uphill without the likelihood of winning. So if most doctors will say, well, if it's not going to interfere or harm, then that's fine. So this kind of goes back to, for patients, being confident enough or intrigued enough to advocate for themselves and ask the right questions, and to expect and want a physician who's going to be mindful and present with them during their treatment planning, and not someone who, for better or worse, intentional or unintentionally, makes them feel self-conscious or bad about asking questions that are related to their own well-being. That comes into the mental health picture, that comes into the stress management picture, all of these things. Patients should be confident enough in their right to have truly informed consent, to not be timid about asking anything. And if the doctor explains to them that there's a real concern, then then they should be able to take that into mind. But things that aren't going to be harmful and maybe treatment enhancing or helpful and contributing to wellness really just play on the ability of a doctor to say, there's more that I don't know than I do, and I'm open to that notion, as opposed to being so stuck in their ways.
Yeah. So I think I always tell, when people ask this kind of question on cancer, I always say that if your oncologist have any question, I will be glad to talk to him directly.
What a kind offer that is. So, all right. Well, thank you so much to everyone for joining this really important podcast to teach people about radiation. There are a lot of learnings we had from today's podcast today. The first is to make sure that you're taking your pre and probiotics to ensure your overall success and really get your gut microbiome totally dialed in for the success and to really build up your core health. Also to consider taking high dose, not everyday dose, but high dose antioxidants. And it's not just one, it's a multitude of antioxidants that can really support you. And we'll be coming out with a protocol from Dr. Prasad that we can share with our listeners. Also to begin to think about digestive enzymes, not to take collagen peptides, and make sure that after we are finishing our therapy, we don't just take all of our supplements out, we actually help to titrate out or to really taper off those to an effective amount. But beyond that, this is an energy game, people. Make sure you're not spending your time focused in fear. Make sure you're equipping yourself to live in joy. Ask the good questions. Make sure you have a doctor that'll listen and be willing to negotiate with you and explain things. And if they're not willing to, call Chad, call Dr. Levitt, because we know he's a person here that's willing to do this. So there are wonderful unicorn oncologists out there that will listen and consider all options. They are there, and I empower each of you to go find them. We have a couple of really exciting podcasts coming up. We have one with Dr. Russ Jaffe, who will be talking to us about inflammation and a variety of different nutraceuticals that is really interesting. We also have Donnie Yance is going to join us. And as you know, he's one of the most influential people to MOJO. So we're really excited to have that combination coming up. We're doing a couple of others around EMF and inflammation. So we've got a ton of great information coming up for everyone. This is just the knowledge bombs we dropped today are all around radiation, and we will be sharing additional information in our follow-up as well. So thank you so much to the listeners. And let me just say one more time, a heartfelt appreciation for Jet, for Dr. Levitt, and for Dr. Prasad. I couldn't be more grateful for you dropping your knowledge bombs on our audience today. So thank you so much for joining us.